Hello, everyone. I'm Tanya Layden, Vice President of Development and External Affairs at APAICS, the Asian Pacific American Institute for Congressional Studies. I'm pleased to welcome you to the 2026 APAICS Health Summit. Today, we'll talk about health policy issues, including data integrity, workforce challenges, geographic disparities, as well as what our partners are doing to adapt to changing conditions and the healthcare industry in order to better serve our communities. Before we begin, I'd like to invite Madeleine Milka, President and CEO at APAICS, to provide some opening remarks.
Hello, everyone. I'm Madeleine Milka, President and CEO of APAICS. Thank you for joining us for our annual Health Summit. This summit brings together nonprofit and corporate leaders, subject matter experts, and elected officials for health policy discussions that affect the Asian American and Native Hawaiian Pacific Islander community and the nation at large. Today's conversations are crucial to understand and to solve the most pressing issues facing our communities with respect to health policy. We will hear from elected officials, corporate partners, and industry leaders as they shape the conversation on healthcare in the United States. Thank you for joining us in these important conversations. I'd like to thank our summit partners, Amgen, Biogen, Blue Cross Blue Shield Association, Bristol Myers Squibb, Compassion and Choices, DaVita, Johnson & Johnson, NYU Langone, Pharma, and Planned Parenthood. Your support enables APAICS to fulfill its mission of promoting AA and NHPI representation at all levels of the political process, from community service to elected office. I hope you learned something new today and share what you learn with your colleagues and community members. Have a great summit.
Thank you, Madeleine. Our first panel is the Access and Affordability Question: Coverage, Costs, and the Future of Care. The pending expiration of Enhanced Affordable Care Act subsidies threatens to widen existing gaps in coverage and affordability for AA and NHPI communities. This panel will examine how rising prescription drug costs and shifting market dynamics intersect with subsidy loss, changes to Medicaid, and overhauls to vaccine schedules, reshaping access to care and the broader medical landscape. Next, I'd like to welcome CAPAC Executive Member Congresswoman Pramila Jayapal from Washington State's 7th Congressional District. Congresswoman Jayapal serves on the House Judiciary Committee, the House Foreign Affairs Committee, and the House Budget Committee. Prior to being elected to Congress, she spent 20 years working internationally and domestically in global public health and development. Please join me in welcoming Congresswoman Jayapal.
Hi, everyone. I'm Congresswoman Pramila Jayapal, and I'm honored to represent Washington's 7th Congressional District. Thank you to the Asian Pacific American Institute for Congressional Studies for inviting me to say a few words before this amazing panel, and thank you to Tanya Layden for the kind introduction. Over the past year, the Trump administration and Republicans have waged a full-on assault on the U.S. healthcare system. Through their big bad betrayal bill, Republicans cut $1 trillion from Medicaid and the Affordable Care Act to give massive tax breaks to billionaires. And as a result, 15 million people will lose their health insurance. Specifically for the Asian American, Native Hawaiian, and Pacific Islander community, these changes will disproportionately affect non-native English speakers, lower-income AA/NHPI individuals, and lawfully present immigrants and refugees. Now, let me be clear. These cuts don't just affect those who rely on Medicaid or the Affordable Care Act. They impact all of us. When people are uninsured and can't get the preventive care that they need, they'll wait until they have to go to the emergency room. And that will impose even greater costs on our healthcare system and will end up increasing everyone's healthcare costs. So to mitigate the immediate harm, Democrats have been focused on extending the ACA tax credits, which we successfully passed in the House. Unfortunately, it's now stalled in the Senate, and millions of Americans are seeing increases in their healthcare premiums. More and more Americans are now seeing just how broken our healthcare system is. How can we live in the richest country in the world, and yet 50% of Americans can't afford healthcare? It's because of big pharma and the greedy billionaires who are raking in enormous profits while the American people suffer. That's why I'm so proud to be the lead sponsor of Medicare for All in the House of Representatives. Medicare for All would provide comprehensive quality health care to every American through a government-issued insurance card. It would expand and improve Medicare so that it covers dental, vision, and hearing, reproductive care, and long-term care. It would improve the provider reimbursement rates in a way that supports providers, including rural hospitals. And best of all, with Medicare for All, there's no more premiums, deductibles, copays, or hidden fees. No more worrying about switching jobs or starting a business because your health insurance is tied to your employment. No more medical debt that's burdening millions of Americans. No more out-of-network providers or AI algorithms that deny you coverage. Medicare for All is the best long-term solution to protect affordability, ensure coverage for our communities, and make healthcare a human right. Thank you again for the chance to speak, and I hope you have a wonderful discussion.
Our moderator, Joyce Liu, is a policy advisor for the Asian and Pacific Islander American Health Forum, where she works on federal health policy issues, including health equity, language access, Medicaid and Medicare, and other healthcare reforms. Please welcome Joyce and our panelists.
Thank you, Tanya, and thank you, APAICS, for holding space for this important conversation today. Over the past year, there have been multiple major federal health policy changes, including the passage of the One Big Beautiful Bill Act, which included substantive changes in access and funding for federal public benefits, including Medicaid, expiration of the enhanced premium tax credits for the ACA marketplace, overhauls of the childhood vaccine schedule, not to mention the evolving insurance markets. Each of these developments have implications for access to care, financial stability for families, and the ability of health systems to meet people where they are. Our panel today brings together leaders from health systems, advocates, and industry who are working to address these key issues. We'll explore what these policy shifts mean in practice, and importantly, what strategies can help protect affordability and maintain coverage for our Asian American, Native Hawaiian, and Pacific Islander communities moving forward. Today, we have Clayton Fong, President and CEO of the National Asian Pacific Center on Aging, otherwise known as NAPCA, Carolyn Ha, Deputy Vice President of Policy and Research at Pharma, Dr. Sandhya Rao, Chief Medical Officer and Senior Vice President of Blue Cross Blue Shield of Massachusetts, and Laurel Sakai, National Director of Public Policy at the Planned Parenthood Federation of America. Please briefly introduce yourselves. We'll start with Clayton.
Thanks, Joyce. Clayton Fong with the National Asian Pacific Center on Aging. We're a national organization that represents Asian American elders around the country, both making sure that our community has the same access to services and programs as everybody else.
Thank you, Clayton. Carolyn?
Yeah, hi. Thanks so much for having me. Carolyn Ha, Deputy Vice President of Policy and Research here at the Pharmaceutical Research and Manufacturers of America, known as Pharma. We're a Washington, D.C.-based advocacy organization representing some of the nation's most innovative biopharmaceutical companies in the nation, and we are really pleased to be on this panel as we are wholeheartedly supportive of ensuring that the great science that our researchers are creating make their way to patients in the community.
Sandhya?
Hi, everybody. I'm Sandhya Rao. I'm the Chief Medical Officer at Blue Cross Blue Shield of Massachusetts. I'm a primary care physician by training. And we, Blue Cross of Mass, are a community-focused, tax-paying, not-for-profit health plan headquartered here in Boston. And we serve about 3 million members.
Thank you. And Laurel?
Sure, thanks. I'm Laurel Sakai with Planned Parenthood Federation of America. Planned Parenthood represents the Planned Parenthood Health Centers, which are one of the leading providers of sexual and reproductive health care across the country, serving over 2 million patients and providing sexual and reproductive health care such as birth control, STI testing and treatments, contraception, and other necessary reproductive health services.
Thank you all. So let's get to our questions. First, we kind of want to provide a bit of background to the panel. So Clayton, how have the massive changes in health policy over the past year, including the One Big Beautiful Bill Act and clawbacks in federal funding for public health programs, affected healthcare access and affordability for families?
This has been an unbelievable year. We're seeing changes and challenges on virtually every front. And it's one thing to see changes in one program here, 2 programs here, 3 programs, but virtually every program has changes in eligibility, changes in criteria, changes like work requirements. So it's going to be quite confusing. Many and then they're also phased in. So we've got the HR1, which basically punts the ball to the states to then develop their plans and proposals. So we've got to be mindful and careful of what's going on in each state, as well as the federal changes like Affordable Care Act. So it's quite a challenging area for our communities, especially for our Asian American elders. This is going to provide a significant amount of challenge and difficulty. 80% of our elders actually speak other than English at home. 60% don't speak English well. 1/3 have no adult in their household that speaks English well. So you can imagine that when you add the challenge of the digital age with the challenges of language, that all of these changes are going to be incredibly hard to traverse. So we're really expecting, we have a multilingual helpline that helps folks through these enrollment and access to benefits. And we're already seeing that we're being slammed with the anticipated changes. But once the Medicaid changes come in full force, we really expect to be overwhelmed, if not already.
Carolyn.
Thanks for that question, Joyce. What we're seeing is that federal funding cuts, like those we've seen at the NIH and CDC, are really cutting into research and investment that supports the development of breakthrough treatments. This research is critical as institutes like the National Institutes of Health provide funding for foundational research that serves as the building block for medicines that then pharmaceutical companies develop and produce for patients in this country and around the globe. So as a result, what we're seeing is these funding cuts to public health institutions like NIH and CDC could mean that patients are facing longer wait times for cures and breakthroughs. And so that is concerning for access and affordability of these new treatments.
Thank you. Laurel, would you like to add on?
Sure, happy to follow up on that a little bit too. I mean, especially what Clayton had mentioned in terms of the changes that we are going to see going into effect because of HR1. One of the things that actually has already gone into effect is the defunding of Planned Parenthood health centers. So that one went into effect right upon passage of the bill. Some of the other stuff they gave more time to. And as he mentioned, states kind of scrambling, even though they had more time, it's a lot of change that's happening. But with the defunding of the Planned Parenthood health centers, that means that, the goal of that bill was for patients to not be able to use their Medicaid coverage at a Planned Parenthood health center. And of the 2 million patients that Planned Parenthood health centers see, more than half of those have Medicaid coverage. So that's more than 1 million people who can't use their health insurance to access reproductive cancer screenings, STI testing treatments, contraception. And Medicaid is the largest payer of sexual and reproductive health care, covering 75% of all public expenditures on family planning services. Additionally, in 2024, 1 in 6 non-elderly people got their health care coverage via the Affordable Care Act's marketplaces. So Clayton was mentioning the changes there. We know that people are going to lose coverage, and when people lose coverage, they lose their access to that care, which results in kind of making impossible choices between whether they pay for life-saving preventative health care or go without care entirely. And just thinking about this population in particular, more than 80,000 Planned Parenthood health center patients identify as Asian or Pacific Islander, and millions within that community rely on Medicaid or marketplace coverage to access that care.
Thank you for that. You mentioned this a bit in your response, but could you speak a bit more on ways the ongoing uncertainty of the federal landscape, including rapid changes in health policy, has influenced the implementation and the stability of the work of your organization's initiatives?
Yeah, happy to take that one. I think we really this new law is sort of one piece of a bigger puzzle that's been kind of attacking sexual and reproductive health for a number of decades now. So we're really in the middle of an unprecedented rollback of sexual and reproductive health care, where rights and protections have been reversed. Investments are fewer and far between, and programs that people have long depended on for access are under siege. And you're seeing this in the SRH pieces directly, and then in public health generally. So really navigating uncertainty has really become a part of our work. And we're constantly preparing to think about what the next attack might be. And some of these things are starting to compound in 2025. 51 Planned Parenthood health centers have had to close, leaving patients with fewer access options for care and with higher travel costs and more challenges in accessing. And more than half of those closures have been in rural areas, so places where people already lack access to care. And what we know is that sort of the status quo continuing is not really working right now. Planned Parenthood providers are doing what they can to meet the needs of the patients who walk through the health center doors. But we also know that we need a more durable sexual and reproductive health care system that is equipped to not only address growing gaps in access, but to also prevent inequities in the longer term. So really what we think about in our work has really been sort of reshaping that landscape to try to make sure that care is fair, accessible, and dependable for everyone. There's a lot of kind of changes in the world right now, telehealth options, those sorts of things that present new opportunities. And there's also, more protections that need to be thought of. And how does this care work? How does it actually work for the people who really need it? So we're kind of trying to think through all of those things as we look forward to kind of trying to build an agenda that works in spite of all these obstacles and in spite of all the many attacks that come at us.
Thank you. And also, one of the big items that have caused a lot of uncertainty is that the Advisory Committee on Immunization Practices, or ACIP, recently in December changed Hep B recommendations, and then HHS further revised childhood vaccine schedules earlier in January. So how can challenges related to vaccine access and affordability, including for vaccines recommended by the CDC, impact efforts to close health disparities gaps across different communities? Carolyn, could you speak a bit about this?
Yeah, sure. Happy to. And again, I'll just start by saying that vaccines are one of the most impactful and cost-effective tools in the public health space that we have for preventing critical diseases and supporting healthy aging, right? So through vaccines, I think they've kind of been this silent superhero tool that we've had. And through vaccines, we've been able to eradicate diseases such as smallpox and polio. And, unfortunately, we are seeing kind of resurgence in other diseases like measles. So vaccines are especially and critically important in the early stages of life for children to build these healthy immune systems so that they can prevent further illness and, like I said, support healthy aging. So as you've noted, Joyce, we started to see some pretty major shifts in vaccine policy and especially in the infrastructure of vaccine policy at the federal landscape through the CDC Advisory Committee on Immunization Practices. And ACIP in the past has made recommendations that really set the schedule for childhood and adult vaccines. And as you noted, there was quite a monumental vote in changing the recommendation on the birth dose of hepatitis B, which disproportionately affects the AA NHPI community. And so that is a concerning, I think, kind of tip of the iceberg changes that we're seeing at the federal policy level, which then has just generated a lot of confusion for pediatricians, for providers, and then also states in terms of kind of the shifting of what vaccines are covered. Are they covered routinely? Do health plans have to cover them? What does this mean for certain programs and the safety net, like vaccines for children? So this has really just set off potentially kind of a patchwork of coverage and access issues around vaccines, where typically in the past, when we're seeing, routine recommendations through evidence-based science that says this entire population, should receive these vaccines for the following reasons that have been grounded in evidence, we're kind of seeing that eroding. And unfortunately, again, we're just seeing a lot of confusion that's been created. But, we're also seeing then states kind of have to jump in and either decide to create their own set of recommendations or, go against, unfortunately, kind of what has been recommended out of the Centers of Disease Control. So again, the shifting landscape of kind of federal recommendations that really used to set the standard are now shifting towards state and some Medicaid programs. I think, we also need to acknowledge that this is coming at a time when there has just been general distrust and mistrust in public institutions, as well as just mistrust of leaders within the healthcare space. So this is really kind of a critical time for us to ensure that we're getting through to communities that maybe have kind of also been a little disheartened by some of the leadership and mistrust in public health officials.
Thank you. And speaking about states and really states stepping up a lot, and the private sector has been stepping up. Sandhya, would you like to talk a bit about the work that Blue Cross Blue Shield of Massachusetts is doing?
Well, yeah. Well, Joyce, on the vaccine topic, and Carolyn, I couldn't agree more with everything you said. I know people are concerned that payers and health plans will react to the shift in thinking and the ACIP and modify coverage. I want to reassure everybody that we at Blue Cross are very committed to vaccine access. We view it as a very critical part of public health and preventative care, as Carolyn so eloquently explained. We and most plans follow the science. That is how we make coverage policy. Our coverage decisions are based on proven, evidence-based research, and we will rely on the recommendations of leading medical societies like the American Academy of Pediatrics and the American College of Physicians, who, as many of you know, have come out with statements reinforcing the evidence that exists for vaccines. So we're relying on that. We believe vaccines are a very key part of keeping people healthy, and we are committed to making sure our members have access to them for all the reasons Carolyn mentioned.
Thank you. And could you speak about what some solutions could be that would strengthen healthcare access and affordability?
Yeah, we've talked a lot about affordability here. And just to put a fine point on it, we in the state of Massachusetts and my colleagues at the other 32 different Blue Cross plans around the country are seeing really unprecedented rises in medical expense trend. And we know this is driven by a combination of many different things, not limited to prescription costs, hospital costs, increases in utilization. And we also are seeing wide disparities in health equity. So we measure the performance on various quality measures, and across racial groups, we see disparities in common services like cancer screening, but also the treatment of hypertension and in maternal health, which are well established. One of the beliefs we have had as a plan for many, many years is that the root cause of the rise in healthcare and in poor outcomes is in the payment model itself. And in America, the payment model is generally a fee-for-service model. This is a model that financially rewards volume instead of financially rewarding outcomes or equity or experience. Many, many years ago in Massachusetts in 2009, we created an alternative payment model, which is called the alternative quality contract, that aimed to curb that incentive on volume and replace it with financial incentives for improved outcomes and improved experience. And we were able to really align with providers on creating care models within primary care that really recognize the full breadth of primary care, that it's not limited to what happens in a specific visit, but it really is comprehensive. And Joyce, what we were able to do more recently when we decided to take more accountability for the racial disparities in health that we were seeing in our data is that we used that platform of financial incentive for outcomes to reward financially those providers who are really making investments and paying close attention to closing racial inequities. And so what that meant specifically is first, we really tried to gather more data. I'm sure this audience knows that the data on race at the individual basis is not great. And so we've been engaging our members to tell us how they identify. And it has taken some time, but we feel more confident about the data we have on self-reported race. Where we don't have self-reported race, we use well-established tools to extrapolate based on other things. But then using that data, we were able to look at our library of quality measures and examine performance across racial groups. And if you look up you can look up on the Blue Cross of Massachusetts website, we transparently show the performance on these measures, which are like mammogram screening, colorectal screening, et cetera. And unfortunately, there are, consistent with well-established studies, there are disparities across our population and the quality of care across racial groups. We then went to our provider partners and said, what resources do you need? What gathering and best practice sharing can we facilitate to help you as a community identify best practices and solutions that really aim to meet people where they are? And it's been very gratifying. It's been one of the more positive interactions between health plan and provider in a time that is, full of a lot of conflict. And so what we've seen out of that, I'll just give you an example that really impacts our community, is that we knew going into this that unfortunately in our population, only 58% of Asian Americans insured by us had appropriate screening for colorectal cancer compared to 68% for whites, about a 10% difference. And so through this program and best practice sharing, we were able to encourage producing more materials in Chinese, Vietnamese, and Bengali, creating text message campaigns that are really tailored to the cultural sensitivities around colorectal cancer screening that are culturally appropriate. And some institutions even investing having patient navigators who look and speak the same language as the patients they're serving. I'm very proud to say that one hospital system, as part of this program, was able to show an improvement from 57% to up to 65% colorectal cancer screening in 1 year of this program. So it's showing to us that we, as stewards of the dollar, really play a big part in how care is shaped.
Thank you so much. Carolyn, would you like to add on?
Yeah, absolutely. And I'm really pleased to hear about the kind of innovative approaches that Dr. Rao is sharing of what they're doing at BCBS of Mass. Again, like investing in kind of the root causes and the real drivers of healthcare costs, really taking another look at that is, really encouraging to hear, and investing in value-based care is really music to our ears. But, unfortunately, I think, we'd like to say more of that, and unfortunately, less of kind of what we're seeing in the traditional, as Dr. Rao alluded to, kind of fee-for-service space and the typical operations of how health plans and other larger pharmacy benefit managers are operating. So, one key solution that we'd like to see is, again, kind of more of what kind of innovative approaches Dr. Rao and her team are taking there, but also addressing more kind of practices from pharmacy benefit managers, or PBMs. Congress recently just passed some important reforms that we think are great at getting at some of those incentives of taking out the financial incentives of PBMs in the system. And there are also reforms that are happening at the state level, which is all, really an encouraging starting point. One thing that probably most people, unfortunately, have needed to experience when dealing with their health insurance or PBM are other types of utilization management tools that sometimes can create significant barriers between patients and the medicines that they need. Without providing kind of more affordable alternatives through restrictive formularies. So, tools such as prior authorization and step therapy are unfortunately kind of more the norm than they are the exception. And so those are restrictive tools that we see that can ultimately limit access and then further burden providers when they have to spend time dealing with the insurance company. So reforms around kind of removing some of those barriers, again, reinvesting those dollars into things like value-based care that Dr. Rao alluded to, we think would be a really helpful start. So, happy to speak more to it, but, unfortunately, half of Americans have experienced, prior authorization or some sort of step rate limiting therapy or access to the medicines that they need. So we'd like to continue to work on that and address, a lot of the vertical consolidation that's also going on within the healthcare system. When the health plan also owns the provider practice, also owns the pharmacy, we think that just leads to greater barriers to care.
Thank you. Clayton, would you like to offer the community perspective?
Yeah, sure. I really appreciate the discussions around things like value-based care, but at the core, I agree with what's being said. But it's a really simple notion, and that is that we've always said that prevention and screening and early detection is the key to lowering costs. Now, whether we need to put financial incentives in it, I'm all for it. But in the end, in our community, what we have is a lot of folks that don't get that information. When I was talking about the language barriers and the cultural barriers and what have you, what we have is a whole block of people who just aren't a part of the information flow. And whereas the tools to reach people on a micro basis are there, we have this trend right now that's kind of disincentivizing language access, disincentivizing kind of, how shall we say this? We do a whole outreach and education effort, not only on doing big events, Ask NAPCA columns that answer questions on osteoporosis or stomach cancer or other high prevalence things to reach out, but we have a multilingual helpline that helps people get information, make appointments for vaccinations, do all of these things. So we try to be full touch all the way through. But what we're finding right now is all of that's sort of being I'll be nice and I'll say it's being disincentivized, if not outright opposed. And it's not right. It's not good for our society. It's not good for our community. And so it's really important that we figure out a way to do this and get back to the bipartisan notion that vaccinations are good, early detection and screenings are good, and that there's no alternate facts in those realities. So I think that's the big picture side of where we go, and where I'd be remiss not to talk about one other piece though that's sort of the elephant in the room for us right now. Laura mentioned how you have the Medicaid cuts coming. But Planned Parenthood cuts started right away. Well, guess what? Also just happened right away is that's Affordable Care Act cuts. And I want to cite some information about this because, you could say that the Asian American, Native Hawaiian and Pacific Island communities benefited the most by the expansion of Affordable Care Act, Medicaid expansions, and the IRA, because we literally went from 16% uninsured to 6% uninsured during that period of time. The biggest increase, the biggest increase in access. And for those that were 65 plus in our community, we went from 6% uninsured, an unheard of 6% uninsured for those over 65, to 1% uninsured, just like everybody else. So we had these gigantic strides. And I'm just worried as heck that we're going to see a reversal of those gigantic strides. Now, I know there's a big conversation that has to go on over what's to balance off. But I do know that I want to add another piece to that, and that is because we deal with elders all the time. The other part of that is that elders prior to this, elders, AA and HPI elders were 20% uninsured before all this happened. That's a monstrous number. And as we deal with elders directly on a counseling basis, we're finding a lot of folks that are just being, I think there are improvements in the system that need to happen overall on affordable care, but there's also improvements. We also just can't cut things off either. But right now, I will say that we're finding the biggest group that's affected are those folks that are around 60 to 65. Those, and I'll give you an example, because it's hard to go numbers, but I'll give you an example. If you're 60 to 65, you're allowed the Affordable Care Act says, hey, you can charge 3 times the premium. And I know you can say, hey, well, what does that mean? Well, as we're going in and working with folks, we're finding that without the subsidy that just disappeared, many of those folks are being asked to bear, a couple might be being asked to bear a $25,000 to $30,000 premium a year. That's impossible. That just completely throws the social insurance model out the window because people can't afford that. And so somehow we've decided that it's okay for elders to be charged 3 times more. And I'm not saying, I don't want to get into the price fixing of it. I just want to say that's not affordable for people, right? Is what it boils down to. So what happened was when we had the subsidies and what have you, but when you take those subsidies away, it kind of bears that reality out there. And so we've got a lot of folks that are getting dropped off. And by the way, that's a premium. And then usually the premium might have a $5,000 deductible. So you might be out of pocket 30 grand, 30, 35 grand before you even get $1 of insurance. That's why a lot of these older folks are going to end up, right now, they may be one of the highest uninsured groups right now. And I don't want to say, we don't, and I'm not advocating that we charge higher premiums for women, but we are charging higher premiums for older folks. But women have higher utilization rates too, particularly childbearing women. But we don't charge higher rates for them. So you've got to figure out how are we going to do this? And we've got to have both the subsidies in place, like capping the amount of out-of-pocket costs. If someone's making $63,000, or let's take a couple making $86,000 a year, they get no subsidy whatsoever. But they could be out of pocket $2,000-$3,000 a month. That's half their income. That doesn't work. That's kind of where we're at right now. So we've got to, and then I'll just end with this. It's a long diatribe. I think we got to find a way to do this bipartisanly, because we can't afford to be jackknifing back and forth depending on what party's in power. we've got to find a way to talk to each other, come up with a bipartisan solution that sticks, rather than go, okay, when one party's in power, we're going to go one way. When the other party's in power, we're going to go the other way, and everybody's confused in the middle. So anyway, that's my 2 cents worth.
Thank you so much, Clayton. And I think you're correct about the uncertainty it brings based off of who is leading the government, right? Laurel, can you talk about some ways our audience can maybe advocate for our community health and well-being?
Absolutely. And I do want to build a little bit on what Clayton was saying too about, kind of the idea of higher utilizers and different costs too, because, I couldn't help but, the comment on women utilizing more. And that was another thing that was addressed in the Affordable Care Act, right, was to not have women paid more. And so just thinking about how all the threads of equality have come through. And I think all the conversations that we're having today in terms of how can we make sure that different populations aren't left out by changes or things made harder. Because I think that's the other thing, we're seeing these higher out-of-pocket costs right now. We're also seeing things like, birth control was supposed to be kind of made out of pocket. We're seeing a lot of no out-of-pocket costs. We're seeing a lot of ways that sort of that benefit is being lessened by there being more restrictive processes around that coverage. And we're seeing, more providers getting cut out. So then you're paying the same price for your coverage and you're having fewer providers available who are actually going to see you. So those are the things all sort of fit in as well. So I just wanted to say a little bit on that too. But I do want to make sure that I'm responding to your question to Joyce. But just thinking about, advocating for this community, for the Asian American, Native Hawaiian, Pacific Islander community in particular too. I think, coming from the Planned Parenthood perspective, one of the things about a lot of the care that we provide is that it can be really stigmatized. So on top of some of the language barriers that many communities face, there's also sort of the stigma that can come from cultural attitudes around access to care, particularly more sensitive or stigmatized care like reproductive care. So we've really tried to do a lot to make sure that we are thinking about ways that we can make the information available to people across different cultures, and that includes a lot of more advocacy via social media and those sorts of things, that people might be able to access information a little bit more directly. We also know that one of the things that has been contributing to miscare and skipping appointments has been sort of fear around the current immigration enforcement agenda. In particular, we know that people have sought out less sexual and reproductive health care, contributing then later on to people having higher needs later on. And we know that over 14 million Asian Pacific Islander people are immigrants to the United States, representing 31% of the total immigration population. So really making sure that we're pushing back against some of those efforts to try to make sure that there are safe places for people to be able to access care is really, truly important. So we're really thinking about how we can, again, sort of break down what has been sort of historic barriers and thinking about ways that we can sort of drive equity across all the advocacy that we're doing and making sure that that's breaking through.
Clayton, would you like to add on to Laurel's response?
Yeah, there's so many bills and so many proposals, and there's so many cuts, and there's so many things going on. I think what we want to try to do is get back to some core, basic, fundamental things we're going to advocate for in this process of access to healthcare and what have you. I think one, we want to make sure that no one is disproportionately affected or hurt by whether it be intended or unintended consequences. Two, we want to make sure that we are not asking for special treatment. We're just asking for equal treatment. And that is that, for the typical American dream experience, first generation comes here and maybe it takes 10 years before you can get here. And so you might, for our elders, they sacrifice a lot, mostly not for them, but for the next generation. And what happens is they might instead, if Social Security is based on 40 years of earnings, you might only have 20 years worth of earnings if you're the original first generation. And if the average Social Security check is about $2,000 a month, and you cut the earnings in half, all of a sudden you're down to $1,000 a month in earnings. And guess what? That puts you under poverty. It just so happens that Asian Americans are 40% more likely to live under poverty that kind of belies the stereotype that we're all rich, thin, and Westinghouse science grads in Ivy League in Ivy League schools. But the reality is, at the same time, we have success in our communities. We have this tremendous generation that sacrificed a lot so that generation could succeed. And we owe it to that generation to be advocates for them. So I would just leave it with these fundamental principles. One, they should have at least the same access as everybody else. That's number one. Number two, there should be nothing that goes after legal immigrants' access to healthcare, benefits, or services. Number three, language is not some foreign thing. It is the story of America. We do not go after Italian or Polish senior centers because they want to have food and language spoken in their culture. We shouldn't be going after Asian or Hispanic centers either, because the language is different. I would merely say that those core tenets are probably where we go. And if we look at the lens of policy through those core fundamental tenets, that's what we ought to be thinking about.
Thank you. And thank you all for the wonderful conversation today. If there's one item you'd like our audience to take away from today's conversation, what would it be? And starting with you, Sandhya?
Yes, if there's one lesson I've learned in all my years of working on reform, but in particular right now with the affordability and equity crisis in mind, is that no one of us can do this alone. Creating affordable and equitable care must be a shared mission, which means that we're all going to need to come together and find compromises. And the example I shared with you about Massachusetts has really shown us that it can work.
Thank you. Carolyn?
Yeah, thanks, Joyce, and thanks again so much for having me on today to cover these important issues about access to healthcare for the AANHPI community. Actually, after hearing everyone, I'm energized by the panelists that we've had on today. I think what we've heard is you're seeing kind of end to end in the healthcare supply chain, right? From the scientists and the researchers all the way down to the patients and the providers. We're actually all aligned today in ensuring equitable access for all. And, as Dr. Rao said, it takes all of us. There is no single reform. We actually need simultaneous policy solutions all working holistically. But, a couple key pieces that I do want to share as takeaways are ensuring that we continue to work on pharmacy benefit manager reform, to ensure that they're taking accountability for misaligned incentives within the healthcare supply chain, ensuring that we continue to invest in research and development of life-saving cures so that patients can continue to access, especially in America, have first access and before the rest of the world for some of these life-saving treatments. And then we need to not keep our eye off the public health ball and ensuring that those that are in public health leadership positions are held accountable, and we continue to have oversight over public health policies, especially in the area of vaccines. So those are kind of three key areas. So again, appreciate everyone having us on today, and back over to you, Joyce.
Thank you. Laurel?
Yeah, I think not that different from what others are saying. It's super inspiring to be with this group of people and talking about these really important issues. And, thank you, everyone, for being a part of this. I think one thing that really sits with me is kind of, I think in various ways, people are talking about putting, patients first and what does the patient need. And obviously some different perspectives on that. But I know I'm often really inspired when I get the opportunity to go to Planned Parenthood Health Center and see everything that they're doing to try to meet the needs of the people coming through their doors, and recognizing that people are coming at it from different perspectives, and how do you actually get that person what they need. So I'm really sort of inspired by hearing folks talk about that in a really similar way. And I think, also recognizing that there is a lot of opportunity in seeing the ways in which there are many systems that appear pretty broken right now, that there is an opportunity to try to think bigger about what the opportunity is to make sure that we can get up to that place of equity.
Thank you. And Clayton?
I guess what I would say is, through this whole upheaval of change and uncertainty, I hope we don't lose track of our core fundamentals around really making sure those that have the most vulnerability, the least access, do get access. I will go back to the whole notion of bipartisanship, because I know maybe that's a magic wand that's really hard in this environment, but I got to believe that it's possible again. And until we can kind of listen to each other and incorporate some version of compromise, I'm not sure. As long as we're kind of in our own on our own corners and not listening to each other, it's very hard to come together. I would just say, it's the year of the Olympics. America's an amazing country. People come here from all over the world because it's the greatest place to live and with great opportunities. But for everybody, there's a great opportunity. There are folks who slip through the cracks. So in this kind of mode of the Olympics, I'll just say we should go for the gold because this country is better going for the gold than anybody. But we just got to make sure that we leave nobody behind.
Thank you so much. And thank you, everyone, for joining us today. You've given our audience a lot to think about and quite a bit of clarity on everything that's happened over the past year. And thank you so much, APAICS, for holding space for this conversation.